This is fine. Fantastic. Thank you so much. So I'm now going to take us, I am the non-epidemiologist that's going to be speaking today, so perhaps something completely different. But I should say that I come to this talk and come to PHRI as somebody who's really focused on putting digital health interventions, including AI as one tool in the toolbox, into practice to try and improve the healthcare system, not really a researcher so much as an implementer. So that's kind of the lens I came here today, and I thought I would sort of start with this, which is a very nice segue out of Claire's talk, which is this kind of question of where is the much hyped AI revolution in healthcare? I'm sure you've seen the same headlines I have, that AI is going to revolutionize healthcare any day now, or maybe it's already revolutionized healthcare, and you'd be forgiven for looking around the healthcare system and going, really? Where is this dramatic revolution? Most of us probably spend more time interacting with AI-type devices in our private lives, with things like our smartwatches or Google Maps or Siri on your phone, than you do in your professional life in clinical medicine. And why is that? So I want to kind of tease that out a little bit, and then sort of talk about why I think some of these forces, how I think that these forces that have kind of delayed the rollout of AI in healthcare, how I think they're going to shape how we're going to see AI start to enter into clinical practice and into the business of healthcare. So to take a step back for a second, we might ask ourselves, what are the ingredients for AI advancement historically? So if we look back over the last 20 years, when we've seen tremendous advancement in the science of AI, not so much always in the application, but certainly in the more basic science of AI, it's almost always been a equation, very simple equation, where advancement equals data plus compute, right? We're all constantly seeing increasing amounts of compute power, just following Moore's law, but also then new computing paradigms that are constantly emerging around distributed processing, GPU compute. And that's been accompanied by major acquisition of new data. So in the 2000s, with the advent of the World Wide Web, or the real popularization of it, we started to see millions and millions of pages of documents loaded onto sites like Wikipedia. And that actually provided, for the first time, an enormous corpora of text upon which to train machine learning algorithms to start to do natural language processing. The ideas and the theory had been around since the 80s, but it was really only once we got massive amounts of data and massive amounts of compute that we were able to make really significant progress. And the same is true over the last 10 years with respect to computer vision. Millions and millions of images have been loaded onto sites like ImageNet, and they've provided the fuel for training many of these new machine learning technologies. And alongside it, the advent of GPU computing, and you have the Gen Xer and millennial video game enthusiasts to thank for that advancements, as they are primarily responsible for bringing down the price of GPU computing. So you're welcome. But if you then think about the state of healthcare, you can understand why we haven't necessarily seen the same penetration of AI. Primarily due to privacy regulations, there's been real limits on the ability for AI scientists to access good quality healthcare data. Now, I want to say, though, that this is changing really as we speak, right? I'm sure all of you saw in the New York Times and Wall Street Journal reported last week that Ascension Healthcare has partnered with Google to put 2 million healthcare records, 2 million patients' healthcare records onto Google Cloud, not just for storage, but to allow Google to do AI research. That is probably going to be pretty transformative, and it's going to drive at least Google's approach to kind of health and AI. At the same time, we see major research centers like PHRI beginning to form partnerships with AI researchers at places like the Vector Institute, and investing in an internal unit to help bring some of these technologies to bear on the extraordinary data that is housed at these research centers, and to form partnerships between the great clinician scientists and AI researchers. So I think with those ingredients in mind, we're going to start to see, we've already seen, Claire showed that great graph of the acceleration of research. That is only going to increase, and we are going to see it's going to become more and more possible to advance this. However, that's only one side of the data equation. So I've talked about the value of data for research, but there is another side to that coin, and that is data for deployment. a couple years ago at my last institution, we'd had some real success with natural language processing to extract clinical features from dictated consult notes. And this was fantastic because it gave us access to data that we'd really never had in structured form before. It was like, in our outpatient clinics, it's like a black hole, and suddenly we had access to all this data. Our hospital was incredibly excited because they felt that we could use this approach to automate health records coding in the back office. We had 50 FTEs who were hand going through every single clinical encounter and coding them. And they're like, you can do that automatically right now. Quite possibly, it depends what your data looks like. And they said, don't worry, we store all of our data electronically. Yeah, as scanned PDFs of handwritten notes. And I mean, AI is getting smarter, but I am not sure it will ever be smart enough to read a clinician's handwriting. Apologies, I know many physicians with excellent penmanship. That was a cheap shot. But this is real, right? I mean, a lot of healthcare institutions are still paper-based. And so what that means is that the applications for AI at many healthcare institutions are going to be limited by what data is actually available to run through those AI algorithms once they're trained at a particular institution. And I think that is going to shape where we're going to see AI really entering the clinical practice and the healthcare market in the early days. So what I think that's going to mean, these two factors, is that we're primarily going to see AI deployment or adoption in areas where there's a reliable source of data for deployment. And also, let's face it, in areas where there's a revenue stream for vendors and value for purchasers. And what I think that's going to mean, really advancements in two major areas, medical imaging being the most obvious, right? We have CT scanners, we have our MRI scanners. These are producing data in extremely standardized ways with interoperable image files in a way that can be ingested by AI algorithms. And I think that's the availability and the quality of that data and their ubiquity across the healthcare system means that that is really where we are going to see major advances in AI and actual clinical deployment of AI in the very near future. And the other area, which has been talked about by lots of you today, is, and I mean wearable devices in the most broad sense, from the Apple Watches that a lot of people in the room are wearing, but also to include things like insulin pumps, the Vitality device that PJ is working on, implantable devices that Jeff mentioned, but essentially devices which are providing a reliable, standardized source of biometric data, where you don't need to worry about the mucky, messy clinical documentation that's in the EHRs that is just going to be, it's going to take years for AI algorithms to be able to make any sense of that. And it's always going to be a garbage in, garbage out problem. So sources of reliable data like wearable devices, implantable devices, medical imaging, we're going to see a lot of that. And then the other area, and this is really following out of the point around value for purchasers, I wrote health records coding here, but it's a stand-in for all back office functionalities on the business side of healthcare. In the same way that Microsoft Office was so disruptive to the office environment in the early 90s, where suddenly a lot of streamlining was able to occur in the back office for many organizations, AI is likely going to provide similar kinds of savings and streamlining. But there's another factor that I think is really going to influence how we see AI enter the marketplace, and that is actually how it's going to be regulated. So some of you may be aware, but the FDA and Health Canada, and actually a number of other international regulators, have begun to give us some clear signals about what the approach to regulation of artificial intelligence in healthcare is going to be like. And like other software products, it is going to be regulated as a medical device. That tells us a few things, but most importantly, it tells us that means that regulation is going to be risk-based. So for anybody who is not familiar, I don't know how to use the cursor. So anybody not familiar with the FDA's approach to regulating medical devices, it's essentially a simple matrix where you have the severity of disease on the left, and then across the top, you've got essentially how much decision-making you're handing over to the AI algorithm or the software. And so non-serious conditions where the AI is just informing the clinical management, then that's considered very, very low risk. If you have something like an implantable defibrillator that's running on an AI algorithm, that's critical and it's being used to treat, so it's considered category 4 of the highest risk. And so that's going to determine, that matrix will determine how much regulatory oversight a particular AI algorithm gets. And the FDA just a few weeks ago released a little bit more refinement to this model. And it's indicated they're going to have a slightly different approach for healthcare providers versus AI algorithms that are more patient-facing. Among them, healthcare providers, one of the key things, in addition to informing clinical management being serious conditions, is that algorithms that are black boxes are going to receive additional regulatory oversight versus AI algorithms that are able to be interpretable by the clinician, which makes, it's nice when regulators do things that make sense. So this makes good sense because a clinician is able, if they're able to interrogate the reasoning of the AI, then fantastic, they can, if they don't agree with the AI's findings, they can at least understand why, versus a black box where you really want a much higher level of rigor associated with that. So just an example the FDA has provided is that machine learning algorithms for which the logic and inputs are not explained, that identifies hospitalized type 1 diabetic patients at increased risk of post-operative cardiovascular events, those types of algorithms will receive the highest level of regulatory scrutiny. And in the case of patients, it's very similar, but the black box condition is really just limited to non-serious situations or conditions. And for patients, the full regulatory oversight will be seen for really anything that informs clinical management is in that serious or critical condition, which again, seems to make sense. But this, what does additional regulatory oversight kind of mean? So those of you who have been following the developments of AI in medicine will probably have noticed, perhaps you may have been somewhat frustrated as epidemiologists, that most of the validation studies that have been published of machine learning algorithms to date have been focused on kind of the left two, really around valid clinical associations and analytic validation. But there's been relatively little actually published around true clinical validation. Not many of us have actually seen outcomes research for the use of AI algorithms in the real world, right? But the FDA is making it clear that that will become a requirement for all software as a medical device. And really then what the higher and the lower risk categories tell us is how independent the FDA expects that clinical evaluation to be. So anything in the category 3 and the category 4 will expect to have independent clinical validation. And I think this is sort of interesting for two reasons. The first is I do think that this is going to mean that we're going to see a lot of industry who are producing AI products are going to focus a lot of their early efforts on category 1 and category 2 AI algorithms. That is where we're dealing with not very serious conditions, or at least even more likely, really just trying to inform clinical management as opposed to trying to treat and diagnose, so that they will, in the early days, be able to avoid really a lot of regulatory scrutiny and the cost that can be associated with clinical trials. And so what that means is rather than trying to replace the radiologist right away, what we're more likely to see is efforts to improve a radiologist's workflow or to improve the accuracy of a radiologist's ability to make diagnoses versus full replacement. And then the other observation I would just say is, I know there's a number of excellent clinical trialists in the room. This will likely be an important growing market for clinical trials over the next 10 years. Now, there are some ongoing questions from regulators around this, and they're interesting ones. One of them is really around the idea of the standard for training data. So a lot of, I think it was actually an excellent point Claire made, that the Apple Watch was tested entirely on US citizens. So there's an open conversation amongst global regulators around the standard for training data. Should AI algorithms be retrained or validated on a national population? If were developed in Germany, do they need to be retrained on the Canadian population? What is the standard for multi-center? Is simulated data ever acceptable as for data training, for AI algorithm training? Is a data imputation ever acceptable? Post-market surveillance, we know, is painful in every area of medical technology. It will be no different here in the area of artificial intelligence. One of the ways in which AI can truly be different from other forms of software and other medical devices is some AI algorithms, though by no means all, are continually learning. And that's a fascinating challenge if you think about it, because it can mean that a single AI algorithm may get different results at different time periods, and they may evolve at different sites, right? And you may actually get different results at different sites. And so how on earth is a regulator supposed to approach that? And it's led to some discussions at the FDA and elsewhere around a total life cycle approach, basically other novel approaches to trying to regulate these technologies. But really, this is all to say that as we try and kind of look to the future of healthcare, I think what we're going to see is as artificial intelligence starts to penetrate into clinical environment, it's going to be very much shaped by where is there large amounts of data for research, where is there actually adequate data to deploy these algorithms in actual clinical practice or in the back office for the healthcare business, and the balance that ultimately gets struck by the regulators around innovation versus safety and effectiveness. So thank you very much for your time.